I think the case of intensive versus non-intensive therapy is still a historic driven concept where induction chemotherapy was considered intensive therapy, and agents like low-dose Ara-C or azacitidine being considered non-intensive. Now, with the implementation of doublets or even triplet therapies in high-risk MDS, but also elderly AML patients, the terminology is still the same, although sometimes these kind of novel combinations also have side effects, the same like the so-called intensive approaches, like prolonged cytopenia, thrombocytopenia, and neutropenia, with a high risk of infectious episodes. But I think we enter now a new avenue, a new path in high-risk MDS patients and elderly, where certain combination of therapies, let's say less intensive therapies, are directed against specific subsets of patients, also from a mutational perspective. On the other side, we have also potentially a renaissance of intensive therapies for younger patients below the age of 70 with the liposomal 7+3 formulation, which I think definitely comes with less toxicity. And these patients, younger high-risk MDS patients, may benefit from these therapies because of a more safer debulking of the disease burden. And this brings them also maybe more safer and with less disease burden into a transplant approach. So I think intensive therapy is still a valid option for a small but not very well-defined subset of patients with high-risk MDS and less comorbidities.